Okay, you may begin with the introductions.
It's okay, Letitia.
Yes, be on the live webinar now.
Okay. Thank you very much. Good afternoon, everyone. I'm Dr. Mohammed Munji Besha, the Afferent Transplant Committee Chair. And on behalf of the Afferent Transplantation Committee, I would like to warmly thank you all for joining us today. So welcome to this webinar titled Kidney Transplantation in Southern Africa, Current Situation and Challenges. This session is part of a series organized by our committee, alternating between scientific topics and regional overviews of kidney transplantation across our continent, Africa. Today's meeting is a valuable opportunity to explore the current realities and challenges in Southern Africa, to share experience also, and to foster collaboration across the continent. We truly appreciate your engagement and your commitment to advancing transplantation in Africa. I ask Dr. Mariam Khadar, the chair of the subcommittee organizing this webinar, the webinar subcommittee of Afferent Transplant Committee, to introduce the moderators. So, Dr. Khadar, please go ahead, please.
Hello, everyone. So we are happy to introduce, to have with us Dr. Shiba. She is nephrologist at the University of the Witwatersrand at Johannesburg, and she is member of the Afferent Transplant Committee and South African Nephrology Society. She interests in dialysis in resource constraint setting, glomerular disease, and transplantation. Hello, Dr. Saadi?
Yes, and I'm really honored to introduce Dr. Walter Molloy, who is a physician and adult nephrologist at Gaborone, Botswana, and adjunct senior lecturer at the University of Botswana. He is also the current chairperson of the Nephrology Society of Botswana. He has been interested in end-stage kidney disease, glomerular diseases, and hypertension. Dr. Miriam?
We have also Dr. Marta Anwoma. She is from Namibia, and she is specialized physician and nephrologist. She is from Namibia and based in Windhoek.
Good afternoon. Thank you very much. I am happy to introduce Dr. Onis.
Not Dr. Saadi?
Yes, please. Our moderator also, Dr. Rumbidzai Dahwa, who was graduated with an honors degree in Bachelor of Medicine and Bachelor of Surgery from the University of Zimbabwe in 2003. She is qualified as a specialist physician and nephrologist from the Royal Australasian College of Physicians in December 2013. Currently a lecturer in the Department of Medicine at the University of Zimbabwe College of Health Sciences and head of the renal department at Sally Mugabe Central Hospital. Welcome, Dr. Rumbi.
Also, we have Dr. Elsa Shisiko. She is head of nephrology department of the Mozambique Hospital, and it's okay. So I think that we can start with the first presentation. Dr. Shital Shiba.
Okay, so it gives me great pleasure to introduce the distinguished Professor Malcolm Davies of the University of the Witwatersrand. He's also the head of the nephrology unit at the Helen Joseph Hospital in Johannesburg, South Africa. It's unsurprising that his research contribution to the Nephrology Society has been invaluable, leading kidney transplantation status barriers workforce in the African context, and some of the largest data in Africa on HIV-related kidney disease, glomerular disease, acute kidney injury, and live experiences of patients with chronic kidney disease, focusing on quality of life, dialysis, and telemedicine. His active involvement in many committees, including this AFRAN committee, the South African Nephrology Society, and African Association of Nephrologists, are merely a few examples of his dedication and indispensable contribution to nephrology in the local and international context.
Thank you, Dr. Chiba, and thank you to the organizers for your very kind invitation to discuss this topic today. It's my privilege to talk about the South African experience with regards to kidney transplantation. I've subtitled this talk, Much Work Done, Much Work Still to Do, for reasons that I think will become apparent as we go through the South African experience of kidney transplantation. So by way of background, South Africa has got a number of transplantation programs in place. We have solid organ transplantation, which includes kidney, heart, lung, and kidney pancreas transplants. We also have stem cell and bone marrow transplant programs, corneal transplant programs, and you might have seen not so long ago in the literature our first composite tissue transplant in the form of a penile transplant. We have both non-related living donor as well as related living donor transplants, and our non-related living donor programs include altruistic directed transplantation. And as we shall see, we have a very active and extensive deceased donor program, which largely focuses on donation after brainstem death. In terms of the funding model of our program, so we've got a parallel, fully public funded program in the state sector, where the government provides funding for all the workup, engraftment, and post-care of both the donor and the recipient in the case of living donors, as well as an insurer-funded program active in our private healthcare sectors. In South Africa, we have got established legislation overseeing the regulation of transplantation, including the National Health Act of 2003, which is an amendment of previous existing legislation stretching all the way back to 1952. We have oversight of our transplantation programs provided by the Ministerial Advisory Committee on Transplantation, and we're also signatory to the Declaration of Istanbul. Our individual programs determine candidate selection of both recipients and donors in consideration of KDIGO guidelines applied to the local context. And we don't have an overarching policy in South Africa to guide selection of donors and recipients, instead, as I said, relying on KDIGO guidelines. And then we also have got two professional bodies that are actively involved in kidney transplantation, so the South African Nephrology Society as well as the Southern African Transplantation Society. So kidney transplantation is an important component of our kidney replacement therapy in South Africa, and this is data from our South African Renal Registry, which shows that sort of overall we have about just close on almost 20% of patients receiving some form of kidney replacement therapy are kidney transplant recipients. If we look at the sort of sub-sectors, so in the state sector, about 40% of patients in receipt of kidney replacement therapy are kidney transplant recipients. So that's roughly 1 in every or 2 out of every 5 patients on kidney replacement therapy have a kidney transplant. In the private sector, numbers are much lower. About just over 10% of patients receiving kidney replacement therapy are transplant recipients. And that really reflects discrepancies in the population groups accessing these healthcare sectors. The private sector tends to be older patients who are sort of poorer candidates for transplantation. That accounts for lower rates of transplantation in that sector. We've got between 15 and 16 transplant centers across our 9 provinces in South Africa, but only sort of 15 of those are transplant centers. There's the 16th, which is more of a cardiac transplant center. These transplant centers are roughly equally distributed between the state sector and the private sector. You'll note, though, that these transplantation centers are really localized in only 4 provinces. So Gauteng, that's Pretoria and Johannesburg, the Free State, that's Bloemfontein, KwaZulu-Natal, that's Durban, and then the Western Cape, which is Cape Town and Stellenbosch. And this means that these transplant centers in these provinces will often provide services to patients from neighboring provinces. So, for example, our center in Johannesburg covers patients coming from Polokwane in Limpopo and sometimes also from places like Mpumalanga in order to provide them access to kidney transplantation. Now, South Africa has, as I've shown, an active kidney transplant program, and it really started fairly early in the history of transplantation. So we started hemodialysis at the University of the Witwatersrand in 1958, and we had our first kidney transplant, which is the first kidney transplant in Africa, at the University of Witwatersrand in 1966. That transplant was undertaken by Professor Mayberg here and Professor Starzl, who came out to lead the team who undertook that first transplant. The second transplant was undertaken in 1967 by Professor Chris Barnard, who many of you will be familiar with as a leader in cardiac transplantation. He undertook the world's first heart transplant the following year, again at UCT. This transplant in 1967, the second kidney transplant, was in fact the first South Africa-only team performing a transplant at the University of Cape Town. And this year, 1967, the second kidney transplant coincides with the establishment of the South African Nephrology Society, or the South African Renal Society, as it was known at that time. So this early start allowed South Africa to gain quite a lead in terms of kidney transplantation. By 1978, our team at Wits University had undertaken 345 transplants. Of note, 277 of those transplants had been cadaveric. And in fact, this is an important point to note, is that in South Africa, our deceased donor program got an early start. In fact, the third patient transplanted at the Wits, under the Wits program, was in fact a deceased donor recipient. And so there's always been an emphasis in South Africa on deceased donor programs. And this emphasis on deceased donor programs resulted in our transplantation research teams taking an active interest in outcomes of transplantation, comparing outcomes between what they used to call cadaveric donors and living donors. And this interest in the discrepancy in outcomes between cadaveric and related living donors prompted our research teams to take an early interest in the role of cross-matching and pre-engraftment sensitization in terms of transplantation outcomes, as well as taking an interest in things, for example, to do with kidney harvesting and transplantation, ways to improve survival after cadaveric transplant. So you can see that this early start at South Africa and the emphasis on a deceased donor program, as I've already alluded to, resulted in an intense interest in research in terms of antibodies and cross-matching of recipients and that effect on outcomes. So you can see early publications from South Africa as early as 1967, being interested in HLA typing, concern about hyperacute antibody-mediated rejection in 1969. So that's 3 years after the program got its start. And you can see also sort of the translation into an early appreciation of the importance of class 2 antibodies as early as 1978 in terms of long-term outcome, both sort of preformed and de novo antibodies. And this sort of interest in the role of sensitization in terms of outcomes then found translation into sort of novel attempts to improve the survival of transplanted kidneys. So in 1970, for example, we have the Wits research team talking about the use of anti-thymocyte globulin, which in those days, Professor Mayers used to harvest from horses held at the Agricultural Research Station of the University of the Witwatersrand. There's also interest in novel treatments like graft irradiation in order to protect the kidneys long-term, ensure extended survival of the transplanted kidneys, and also interest in things like total lymphocyte irradiation, now finding its role, for example, in chimeric transplantation programs in various centers in the US. From this sort of like appreciation of the importance of the immune system in terms of long-term outcomes of transplanted kidneys, and the shortage of donor organs which existed at that time also provoked interest very early on, here as early as 94, in terms of xenotransplantation, with the research team at the University of Witwatersrand actively investigating the role of primate kidneys to improve access to transplantation in South Africa. And South Africa's contributions to the science of transplantation didn't end there, but the country has continued to contribute on the international stage, most notably with Prof. Muller from UCT, who initiated the first HIV positive to HIV positive transplantation program in the world back in 2010. And South Africa since then has also continued to contribute to the science of transplantation. So we have the UCT team here led by Dr. Bade, performing ABO-incompatible kidney transplantations at UCT using immunoadsorption columns. And we have the same team reporting on the use of donors after circulatory death in terms of graft outcomes. So looking at ways of expanding access to transplant by increasing donation. The private sector has also been actively involved in transplantation and has contributed significantly to the science thereof in the local context and internationally. So here we have Professor Fabian from Wits Donald Gordon Medical Center reporting on that program, which initiated in 2004. So the Wits Donald Gordon Medical Center is a joint university private facility, which, as I say, initiated its kidney transplantation program in 2004 and subsequently has evolved to also undertake pancreas kidney transplants. Here they are reporting on outcomes from that program. And it was this team also which undertook the first paired kidney donation in South Africa back in 2015. Johannesburg has, in addition to the Wits Donald Gordon Medical Center, also the Mill Park Hospital, which undertakes transplantation. And back in 2016, that private facility was the first one to undertake a combined heart-kidney transplant in South Africa successfully. Perhaps another important area where South Africa has contributed to transplantation in the African context is by its training of foreign graduates in the field of transplantation. So this is data from the transplantation survey that we previously presented, where 29 of respondents to that survey indicated that they'd received their training in transplantation in South Africa. So South Africa continues to share its expertise in transplantation, not only with the rest of the world, but particularly with the rest of Africa. So that's the good news from South Africa, but unfortunately, there's also some bad news that I have to share with you. Here is data from Prof. Musa analyzing South African registry data again, and in essence showing that if we look back over the past sort of like 2 to 3 decades, year on year, there's been an overall decline in the total number of kidney transplants undertaken in South Africa. That's the black line here. And that decline in transplantation is largely driven by a decline in transplantation occurring in the public sector. You can see that in this table here, analyzing the number of transplants undertaken in the various provinces between the public and the private sector. You'll see that it's really only the Western Cape, perhaps the Free State, where the public sector, in other words, the academic institutions, continue to contribute the bulk of transplants. In Gauteng and in KwaZulu-Natal, the number of transplants undertaken in the public sector is declining relative to that in private. This apparent improvement in the number of transplants in the private sector is really largely driven by increased living donation being undertaken in the private sector. That's this purple line here. Important to say that South Africa, as in other or in sort of keeping with the global experience, has shown a decline in deceased donor transplants, both in the private as well in the state sector over time. So overall, we have a decrease in the number of kidney transplants taking place. We're also doing particularly badly in expanding access to kidney transplantation for our most vulnerable ethnicities. So we're all aware that people of sub-Saharan Black African ethnicity carry increased risk of end-stage kidney disease. And here you can see that, again, in analysis from registry data by Prof. Davids, that our Black African population, which constitute the largest ethnic majority or ethnic population in South Africa, have much lower access to kidney replacement therapies, including transplantation, compared to other ethnic groups. And that's an important point to consider. And the reason for that has to do with South Africa's colonial and apartheid past. And here you can see data from the Statistics South Africa, which collects data on a variety of parameters, but includes access to healthcare services by population group and by province. And the important point to make here is that the blue and the red bars represent access or patients accessing healthcare through the public system, so the state-funded system. You can see that between 60 and 80% of South Africans are reliant on the state healthcare system for access to healthcare, including kidney replacement therapies. And this system, which is funded by the state, would be where patients who don't have access to medical insurance are likely to receive treatment. And here you can see data again coming from the Statistics South Africa group showing that Black African ethnicity, who again contribute the bulk of the South African population, are less likely than any other population group to have access to private medical health insurance, and so are more likely to depend on the state healthcare sector for their kidney replacement therapy. So South Africa is the most unequal society in the world, where because of our colonial and apartheid past, the bulk of our Black African population live in poor socioeconomic circumstances and therefore must depend on the state sector for access to kidney replacement therapy. And since 1994, the advent of democracy in South Africa, the state has only added 3 kidney replacement therapies to the existing 26, whereas in the private sector, which is funded through health insurance and which is accessed by our Caucasian and Asian population, there's been a dramatic increase in the number of kidney replacement therapies by almost 250. And what that effectively means is because the bulk of our population depend on the under-resourced state sector, access to kidney replacement therapy, including transplantation in South Africa, is actually amongst the lowest in the world per million population. And this reliance on the state sector for the majority of South Africans has a direct effect on the number of people who can be transplanted. So here, for example, is data coming from our sister state units at Groote Schuur in Cape Town and Universitas Academic Hospital in the Free State. And this is showing the work of the renal unit committees that in essence decide whether or not a patient can be initiated onto dialysis with a view to being waitlisted for transplantation. And what you can see here is that the bulk of patients presenting to these units are going to be excluded from kidney replacement therapy, somewhere between 70 and 80%. And that's purely because of resource limitations, that the state sector units are full and cannot take on new patients. And the tragedy of this lack of access to kidney replacement therapy is that we are sending home young people who are working with dependents who are dying of kidney failure without being able to access kidney transplant. So you might well ask, well, the private sector shows that you can improve transplantation using living donors. So why can you not increase kidney transplantation in the state sector through living donors? And here is work by my colleague, or my former colleague at Helen Joseph, Dr. Dial, where we compared the outcome of living donor evaluation between our patients of Black African ethnicity and non-Black African ethnicity. And you can see that Black African patients are much less likely to be accepted as living donors to their relatives. And the chief reason for exclusion of our Black potential candidate donors were medical exclusions. So these included higher rates of HIV amongst our potential Black donors. That is again a function of South Africa's apartheid and colonial past, with forced migrancy resulting in the disruption of the traditional family unit and increasing the prevalence of HIV in this population. And beyond that, there's also much higher rates of chronic kidney disease, which may find expression in hypertension in our Black African potential donors, as you would expect, given what we know about the genetics and effects of socioeconomic conditions on risk of chronic kidney disease in patients. So what we, in essence, discovered through the study is that our Black African patients would have to bring 4 potential donors for us to find one candidate donor who would be cleared from a medical point of view to transplant. So not so easy to expand donation through a living donor program in South Africa. Another effect of South Africa's apartheid colonial past in terms of the socioeconomic status of the vast majority of our population is that many patients presenting with kidney failure are not actually eligible for consideration for transplant as recipients on a medical basis. This is work from Dr. Musson, which is in preparation for publication from our unit at Helen Joseph, where we analyzed reasons for exclusion from transplantation amongst 400 patients presenting with CKD stage 4, stage 5 to our unit. Important to say that the actual most common reason for exclusion from our program was immigration status. So non-South Africans in South Africa are not automatically guaranteed access to kidney replacement therapy, including transplantation. The bulk of these patients are young and are male, and this speaks to economic migrancy into South Africa, with these patients subsequently developing kidney failure in South Africa and then presenting to our state sector institutions for treatment. I believe our colleagues are going to speak about the challenges in kidney replacement therapy in our neighboring countries, which also contributes towards the presentation of these patients to our unit. We are increasingly seeing patients coming from our neighboring countries to South Africa seeking treatment for kidney failure with that diagnosis already established. After immigration status, the next most common reason for exclusion of patients from our as potential recipients in a kidney transplant program were infectious indications, chiefly uncontrolled HIV infection, then followed by cardiovascular contraindications, the leading cause of which was pulmonary hypertension. That itself is quite interesting. You may be aware that there's recently diagnosed a form of cardiorenal syndrome, which features primarily pulmonary hypertension as its manifesting feature, and is more common in people of Black African ethnicity and is related to underlying salt-sensitive hypertension. So that might account for that finding. And then newly diagnosed uncorrectable outflow tract obstruction, chiefly in the form of ureteric strictures, but also abnormalities of bladder function. And then finally, psychosocial and malignancy contraindications, and the leading contraindication to transplantation from a malignancy point of view being cervical cancer. South Africa has amongst the highest rates of cervical cancer in the world, so perhaps not surprising that we should find that. So beyond the sort of difficulties in expanding transplantation programs in South Africa on the basis of lack of suitable donors and lack of suitable recipients are other challenges which were highlighted again in the Afran Transplantation Survey. And 3 of the most important challenges or barriers to transplantation highlighted by South African respondents were a lack of uniform policy, lack of government support, and then the cost of kidney transplant. And these are sort of barriers to transplantation which were in fact widely reported by our colleagues throughout Africa. So one of the issues related to the cost of transplantation and lack of formalized policy, and then again pressure on our transplantation programs by virtue of challenges experienced by our neighbors, is that occasionally challenges occur in the form of kidney transplant trafficking and tourism. And so it would be important to acknowledge that South Africa has not been immune from this. And a decade or so ago, we had an incident where there's a significant organ trafficking program exposed, which appeared to involve collusion from very high management structures in the private industry. So by way of conclusion, South Africa has many successes to report in kidney transplantation. We were the first African nation to commence transplantation in 1966. We were the first African nation to commence with the deceased donor program. We were also the first African nation, the first nation in the world to commence with an HIV positive to HIV positive transplantation program. We are also the first, to my knowledge, program to have undertaken deceased or donation after cardiac death. And we are the first nation in Africa to have undertaken ABO-incompatible transplantation using immunoadsorption columns. We also have success to report in the sense that our programs, that we do have a fully state-funded program, that we have some oversight by bodies at a local and national level, and we have legislation in place. And that we have made contributions to the growth of kidney transplantation programs in our neighboring countries through training, as well as contributions to the science of transplantation, particularly in the fields of humoral rejection and desensitization. But there are still significant challenges to kidney transplantation in South Africa that are important to acknowledge. And these are chiefly that we have significant resource constraints that limit access to kidney transplantation and indeed other forms of kidney replacement therapy like dialysis for most South Africans, and that we have genetic and socioeconomic factors which are legacies of our colonial and apartheid past, which affect living donor recruitment and indeed contribute to many patients being excluded as potential transplant recipients on the basis of medical contraindications. And our deceased donor program is subject to low levels of donor recruitment, although, as I've said, that is a sort of global phenomenon. Then we also have a lack of universal policy, government support, and the cost of kidney transplant, which remains significant limitations to expansion of our programs. Thank you for your attention.
Thank you very much, Dr. Malcolm, for this outstanding presentation. I think we'll keep the questions in the end. So I have the pleasure and honor to present my friend, the second speakers, Dr. Davy Ifmin-Wan from Mauritius. Dr. Davy is trained in the UK and worked as a consultant nephrologist in Coventry before returning to Mauritius in 2012. He joined as the Ministry of Health as a nephrologist and became head of department when nephrology became a standalone specialty in 2021. He's founding members and past president of the Renal Association of Mauritius. He's presently attached to Victoria Hospital in Carter-Burns, but had administrative responsibilities for all 5 hospitals in Mauritius. So, Dr. Davy, please.
Sorry, I just realized I was muted. Thank you, Prof. Bacha, for this introduction, and thank you to Afran for allowing me to speak today. Can you see my screen?
Yes, it's okay.
Right, so I'm going to talk about kidney transplantation in Mauritius, and many of you will be aware of a postcard image of Mauritius, but the reality is very different on the ground. Mauritius, in terms of GDP, we seem to be doing relatively okay compared to Africa. We can see the numbers on the left-hand side. And our country has known a very fast development in the last 40 years. We're now considered an upper middle income country, although we don't feel like it. And the health expenditure is 5.7% of GDP. In terms of African context, you can see Mauritius, which is very small, to the southwest of the African continent. And in terms of GDP, if we look at the 54 countries in Africa, we're 31st by GDP. But if you look at the GDP per person, per capita, we're second. We're 48th by population size, so one of the smallest population in Africa, and second by Human Development Index. Our ethnic makeup is very different from mainland Africa. As you can see, that 2/3 of the population comes from the Indian subcontinent. 28% come from Africa, we call them Creole, and a few percent of Chinese and Caucasian. And atypically for Africa, our population is now shrinking since 2020. That was probably brought forward by 5 or 10 years by COVID. If you look at the population structure, in red in 1990, we had the typical pattern of a developing country, but now we can see that less and less children being born, and the biggest population ranges are between 25 and 65. And the prediction is we're going to have a very old population by the year 2100. The life expectancy had improved from the 70s to 2010, but unfortunately, the last 10 years, we have stagnated. The other worrying thing is, in addition to having less and less children, the proportion of children being born with low birth weight is increasing. It was less than 15% in 2006, and now is above 20%. And we're in the top 10 of diabetes. In 2021, we were 8th, and we're predicted to go to 4th place by 2045. So the Mauritian population is very sick. There's a high prevalence of diabetes, 20%, hypertension, 27%, hyperlipidemia, 36%, obesity is 35%. This is from the 5-yearly Mauritius non-communicable disease survey. And if we look at 6 cardiovascular risk factors listed on the screen, shockingly, 77% of the population had any of 3 risk factors, and only 13.5 didn't have any of these risk factors. And there's something surprising happening in Mauritius. If you look at our sugar consumption on the left-hand side, classify people in terms of consumption of sugar, you expect that more sugar you consume, the more diabetes you would get. And we have a lot of diabetes for the amount of sugar we consume. And we actually consume the same amount as South Africa, but vastly different levels of diabetes. If you look at obesity, it's the same story. We're not particularly bad in terms of obesity prevalence, but we have a lot more diabetes than most other countries in the world. And if you look at GDP per capita, the general pattern is the more richer you have, the more NCD you have. But somehow, again, Mauritius seems to have more NCD than we would expect for our GDP per capita. If you look at the socio-demographic index on the right, you can see that countries with a low index have a certain level of DALY, disability-adjusted life years, and richest countries have the lowest. And again, we are top of the pile. So what is the Mauritian healthcare system? So we're a small island, about 40 by 60 kilometers, although we do have a few outlying islands. The main island is divided into 5 regions, each with a main regional hospital, and there's a network of local health centers. There is also the island of Rodrigues with its own hospital. So the public hospital is totally free, including drugs and transport. And the same thing for dialysis and transplant. Drugs like EPO and transplant immunosuppression is also free. If you look at the official NCD survey, they tell us that the prevalence of albuminuria is falling from 2010, 2020, halving, and also fall in the EGFR less than 60. However, this doesn't meet with our daily experience. And interestingly, in 2020, the Global Burden of Disease CKD study showed Mauritius second in terms of prevalence and also deaths, and third in terms of DALI. And we estimated almost 220,000 cases out of a population of 1,260,000 people. And actually, the latest literature from earlier this year showed that we are first in terms of age standardized prevalence and DALI rate in the world. And this chart is the similar one that I showed earlier in terms of socio-demographic index, except it's been flipped. And so the worst country is at the bottom, and here we are, Mauritius. So this is a map from the Global Burden of Disease, CKD, and you can see the hotspots in red, and Mauritius is here. So we are number 2 in 2017, but you can notice that many of the small countries in the world have high rates of CKD and actually NCDs. This graph shows the level of cardiovascular disease, cancer, and diabetes, and respiratory disease in the world, and the small island states are in yellow, and Mauritius is here. And you can see that there is a increased number of small islands on the right-hand side. I think small island developing states share a common problems, and in terms of population pool, access to logistics, isolation, and so on. This shows the number of dialysis patients month by month in Mauritius since 2006, and there has been a very fast increase, doubling from 2006 to 2020. However, with COVID, there's been a flattening of the curve since then. And this shows, in addition to the total of patients on hemodialysis at the end of the year in blue, you can see the number of new patients, which is an incredible 800 patients, and also the very high level of deaths on dialysis. And if you compare Mauritius to the USRDS list of top countries in terms of incidence of treated kidney failure, we would be second with about 500 new cases per million population per year. In terms of prevalence, we are lower down, and the discrepancies due to the high mortality in Mauritius. So in Mauritius, we have 1,579 patients on hemodialysis, only 2 or 3 on peripheral dialysis, and 175 or 10% with a functioning transplant. So we can see a lot of smaller islands that belong to Mauritius, very far apart, but the main island is Mauritius, and you can see the numerous hemodialysis units, and also 1 unit in Rodrigue. The transplant center is in Victoria Hospital in the center of the island. This is the evolution of the nephrology workforce in terms of pure numbers is going up, but if you account for a number of patients, so if you measure per 1,000 KRT patients in the public sector, there hasn't been any progress in the last 25 years. And if we compare with the number of nephrologists per million population on the right-hand side, we seem to be doing quite well compared to many countries in Africa and South Africa. But if we consider the number of patients we dialyze, then we are bottom of the pile. This is the population pyramid for the dialysis patient. You can see there is a overrepresentation of men and people in the elderly group. This is not surprising. So this is an example of one of the newer dialysis centers in Mauritius. So a quick history of nephrology in Mauritius. So the first form of kidney replacement was in the early 70s with acute PD. First transplant, kidney transplant was in 1980. I will talk more about that. First hemodialysis in 1991. First transplant in public hospital was in 19 1992. And in 2017, our transplant program came to a stop. Patients were sent abroad. And in 2022, there's been a restart of the program. So we can see that we have a abnormally high and rapidly increasing burden of chronic kidney disease in Mauritius. Unfortunately, there are no specific policies in Mauritius towards kidney disease. It's something that we're working on to remedy. Grossly inadequate workforce. Our renal services remain focused on hemodialysis at present, and too many of our patients start dialysis as an emergency. Patient education and support is very limited, and we have very high mortality of kidney failure patients in Mauritius by international standards. Our diagnostic and therapeutic services are several decades behind advanced countries, and absence of systematic data collection, auditing, and clinical research. Now let's talk about the living donor kidney transplant, which actually started well, not as early as South Africa, but still relatively early in 1980, but was led by a Mauritian-born neurologist and nephrologist trained in Dublin, and they came to Mauritius, and within months we were doing transplant in a private clinic. The cross-match was sent to South Africa, and as Dr. Davies was mentioning, South Africa has been instrumental in helping neighboring Southern Africa countries in their program. Unfortunately, this was stopped related to high morbidity and a change of government. And the following years, many patients went abroad to South Africa and India, and some of them went to buy kidneys. Unfortunately, 1 out of 3 did not make it back alive. And then in 1992, the government invited foreign teams from Mumbai and South Africa, including Professor Khan from Cape Town, and they operated on 48 patients, and they trained one local surgeon in Mauritius, and that was Dr. Upadhyay, and Dr. Gaya, the nephrologist, also collaborated in actually what is now an unequal period in Mauritius between 1996 and 2013, where we were doing about 18 transplants a day, giving a transplant rate of 15 per million population per year. This unfortunately came to an end with retirement of transplant surgeon. I wasn't aware of this thesis until a few months ago, which I looked into the data from that period, and you can see that the average age of a recipient was 34.6, and most of them are relatively young, and with a male to female sex ratio of 2.3, and about 12.5 of these patients were diabetic. And this is the Kaplan-Meier curve for patient survival over 10 years and up to 10 years, and also for the graph on the right. And so it's not as good as more advanced countries. And actually the first few years with a local surgeon, we had quite a high mortality rate, but thereafter things improve quickly. This is the relationship of the donors to the recipient, mostly siblings, and most of the donors were between 20 and 39, and quite an equal distribution between male and female. And interestingly, there's a number of recommendations made by this doctor, but I will see whether it's been taken into account a bit later. So after 2014, we went through an uncertain time because the second transplant surgeon did a few cases, but he also retired. The ministry decided to send patients at their cost to India for transplant, and 47 patients went there over a space of 7 years. There were 6 patients that were transplanted in a private clinic because the law was not fully proclaimed at that time. And then since October 2022, we had visiting foreign teams up to now. So we had 3 different teams from India and UK coming for a week each. And then we had Professor Nizam Mahmoud, who's a retired professor from Guy's Hospital, who came for 6 and 3 months. And during that time, he not only did the surgery, about 20 of them, but also was very keen to train the staff, namely the surgeons, but also organized training for the transplant immunology lab. That took quite a few years, but now our lab has the latest kit, and they've moved from complement to flow cytometric cross-match, and they estimate DSAs as well. We instituted weekly MDT meetings. We have now 3 transplant coordinators, and they are invaluable in the assessment of our patients. We work through transplantation guidelines, pathways, and worksheets, and we introduced plasma exchange in 2023. However, we had very limited progress in kidney biopsy. When I came back in 2012, I started doing the transplant biopsies and native biopsies, but our level is quite low compared to other countries. Many patients are unwilling to have kidney transplants. And so many of the younger patients who normally do not have diabetes do not have a histological diagnosis. In addition, we do not have a trained histopathologist in public hospital, and so the sample has to be sent to a general histopathologist in a private hospital in Mauritius for an initial opinion, and then sent to India to a major lab in Delhi, and it takes 2 or 3 weeks for a result. So this is not very good if we're trying to find out if a patient has rejected or not. So during the last 2 years, so between August 22 and July 24, we went through all our workup and analyzed, and we found that we had gone through 205 donors for 165 patients, and at that time, 34 were still having workup being completed. So the patient who actually completed the workup is 171, and which only 30 were transplanted, 2 were awaiting surgery, and 139 were unsuitable for transplant. So the transplantation rate is about 19%. So the patient pairs were unsuitable for transplant. The great majority were due to donor factors at 59%. And you can see that the biggest reason was because of diabetes, and pre-diabetes 24.5. And some of them actually had renal pathology, some withdrawal, psychosocial factors, and others. There were recipient factors 60.5, including withdrawal and death, and immunological factors in 23%, and mostly due to ABO incompatible, which obviously we cannot do in Mauritius. If you look at sex and kidney donation, I wanted to see whether there was any bias against the female sex. So in terms of dialysis population, female 34.5. But in terms of patients who recipients that have been worked up, potential recipients have been worked up, the percentage is 37%. And the actual kidney recipients, 43.5. So there is no evidence that we have a system which is biased against women. In terms of kidney donors, there is about 50-50, whether we look at potential kidney donors and also actual kidney donors. Interestingly, if you look at the wife and husband donor ratio, it's about 9-5 or 7-3, which is to be expected given there are twice as many men as women with kidney failure. If you look at diabetes, the general population below 65 in Mauritius, we have about 30% with either diabetes, new diabetes, and pre-diabetic. And it's interesting to see, look at the bottom, if you're looking at potential kidney donors, about 17% were diagnosed for the first type of diabetes and pre-diabetes. In terms of the population with on dialysis, we have a percentage of diabetic of 45, And looking at those that start workup, only 29% diabetic, and by the time we reach the actual kidney recipient, is 13%. So we have a system which is biased against diabetic patients. Most of it, I presume, is due to the high morbidity in these patients. So this is an overview of live donor kidney transplant in Mauritius up to now. And actually, I'm looking at the better years, we're about 9 to 15 per million population, which is puts us somewhere between UK and France. So has the live donor program taken off? Unfortunately, no, because our surgeons are still not trained. There's been a lot of churn in the trainees. We've had a lot of issues with procurement of regions for the HLA lab in the 2 years ago. We had difficulty getting radionuclides post-COVID, various issues with laboratory equipment breaking down, and also the length in procurement and awaiting bureaucratic approval. So we're still dependent on visiting teams, and it seems that potentially we might have a partnership with a surgeon from Cape Town. What about deceased donation? In terms of law, there was a law in 2006 which was voted but was not promulgated. It was in one section only for the transplant board. It was a living donation was restricted to relatives, and the deceased donation was an opt-in system. But in 2018, a new law was voted in, and it's not restricted to relatives, and it is an opt-out system with increased powers to the transplant board, and it is now fully promulgated. So there's no legal impediment for deceased donor transplant in Mauritius. In terms of public education, we know that it's very slow to move the public's views and opinions on transplantation, especially when it comes to deceased donors. Unfortunately, we've just had 2 workshops many years apart, and these were very targeted to professionals over NGOs, and the general public has no idea of what's happening in terms of the law and what are the future plans, unfortunately. We've had a visit from the UK in terms of training for brainstem and help us to draft protocols and guidelines. We've had nurses gone to Birmingham for organ donation training. And so if we look at the disease organ donation map, we have kind of reached some targets, but there are things like organ donor registration, ICU preparation, but we have not moved at all, and public information campaign. We looked at our dialysis population, and we found out that out of 1,500, we estimated that most of the people below 50 would be interested. That gives us 390, and that was our initial target, and then gradually moved to the older ages. And we actually, in 22-23, we screened 140 patients, and they had their actually typing antibodies done. Unfortunately, we didn't get the go-ahead for the program because other bits were not ready. And I've worked on a kidney allocation algorithm, well, just say a hybrid of what's being done elsewhere, nothing new. So looking at the second part of the roadmap, so transplant waiting list, we started on it, was not completed. Organ allocation, we need support in terms of IT and office. We have full laboratory support. We have not moved with organ retrieval, and we still lack trained surgeons, not enough nephrologists for kidney implantation. So this is a quick dashboard for our plan. So going back to the thesis I mentioned earlier, in red of the things that we haven't been able to do is establish a donor and recipient registry, alternative immunosuppressive treatment protocols, and offer long-term psychological support for recipient and donor. We've kind of started a renal biopsy, but there's a lot more to do. And a kidney transplant center has been built in the south of the island, but there's still 1 year to go. And these are what I would like to think are our aims. But of course, we need to get the live donor kidney transplantation to start before moving to the other aims. The first floor is caters for 60 dialysis machines, which is very scary, but it illustrates the amount of problem we have in Mauritius with kidney failure. We also plan to do urology and vascular surgery in the same building. Just a quick publicity for the Renal Association of Mauritius. So Mauritius is not a paradise for healthcare, health and healthcare. There are particular difficulties of being a small island state. The biggest hurdles we've found is not only funding, but also bureaucracy and societal obstruction. Kidney transplantation is highly multidisciplinary, and it's very difficult that people move in if there's no buy-in from the top. Needed for a lot of resources and logistics. There's so much to do. However, we all know that transplantation is worth it when we see patients, donor and recipients decades after still doing well, and some of them getting married. Thank you.
Thank you, Dr. Davy, for the
Dr. Walter
presentation.
Molowi, please.
Thank you, Dr.
Could
Davy,
you
for the
please
presentation.
introduce Dr. Gordana Kavrik, please, and Dr. Abid Sheikh?
Thank you very much. Let me take this opportunity to introduce my two colleagues, Dr. Gordana Kavrik, first, who is a consultant physician and nephrologist with over 30 years of experience in Botswana. She has a medical degree and specialization in internal medicine and master's and PhD in nephrology from University of Belgrade, and that's in Serbia. And she also has a master's of public health from Wits University in Joburg. She is also an adjunct lecturer at the University of Botswana Medical School, and she's in charge of the residency training program. She's as a home mentor for about 5 young nephrologists who are sponsored by ISN in Botswana. And she's been instrumental in setting up nephrology services and dialysis in the government facilities under the Triple P with the government. And she is currently in charge of 3 hemodialysis units in the country. The next speaker from Botswana who will follow after Dr. Kavrik is Dr. Abid Mobashir Sheikh, who is a consultant physician and nephrologist who got his adult nephrology training from the University of Cape Town. He works currently as a nephrologist at Sidlaha Private Hospital in Gaborone, and also at the Sekitimina Teaching Hospital, which is a big state-owned hospital in Gaborone. He is also a member of the Nephrology Society of Botswana, and he has key interests in kidney transplantation, hemodialysis, and glomerulonephritis, and especially lupus nephritis. I will allow at this point for Dr. Kavrik to start with her talk, after which he will be followed by Dr. Sheikh on the Botswana experience. Thank you very much.
Good evening, everyone. Greetings from Gaborone, Botswana. In Botswana, we will say Dumela. I'm going to give an introduction of, give a bit overview of renal services in Botswana, and my colleague, Dr. Sheikh, as Walter Molloy has introduced, is going to give our prospect of the kidney transplantations that we have done so far in Botswana. For those of us who don't know much about Botswana, we are a landlocked country located in the South Africa, bordered with South Africa, Namibia, Zimbabwe, and Zambia. We have a small population of 2.5 million people, 75% is urbanized. Country is huge, size of Texas or France. Languages that we use is English, which is official, and Setswana is our national language, plus we have a number of other local languages. Ethnicity, we have there is predominantly Botswana or Tswana speaking. So country is Botswana, people are Batswana. And a tribe that we have here is Tswana. It makes about 80% of population. We have a stable democracy, one of the Africa's least corrupt nations, with uninterrupted democracy since independence, 1966. 1966 is when we gained independence. We were protectorate up to now. As you heard from Dr. Davis talk, Professor Davis talked, that's the time when South Africa had already had first transplant done. Our economy is based on diamonds. We are one of the top diamond producers in the world. One of the most famous is Drunning Mine, which is one of the richest diamond mine globally. We have fast-growing economy that transformed Botswana as one of the poorest nations at independence to upper middle-income country. This is the map of Botswana. As you can see, most of the towns and settlements are on the eastern part. The western part is Kalahari Desert that takes about 70–80% of the country, and Okavango Delta, which we are very proud of. It is a UNICEF protected area, and it's famous for tourism. But most of the activities, most of the industry, most of the population live on the eastern part of the country, where two main towns, which is Gaborone, which is our capital, which is almost at the border with South Africa, and Francistown, which is nearby the Zimbabwean border. Our health system, while advanced compared to many other African nations, faces several significant challenges that impact service delivery, equity, and sustainability. There are a few key challenges. Number one is our high burden of infectious disease, namely HIV/AIDS. Botswana has the fourth highest HIV prevalence. At some point, some 20 years ago, we were actually number one in the world. So right now, we still have 20.3% of adult population living with HIV. Despite free antiretroviral treatment provided by the government, it basically covers 85% of adults, and new infections are still in race, with a higher prevalence in women compared to men. Obviously, we have other infectious diseases, namely TB, diarrheal diseases, malaria. We just now have outbreak of malaria, which are compounding our already complex health situation. It obviously causes resource constraints. We have funding gaps. Our health expenditure is 4.5% of GDP, which translates into $875 per capita. Other compounding factors that are restricting our access to the healthcare is staff shortages. We have density of physicians only 0.37% per 1,000 people. And in rural areas, it's even worse, facing with severe nurse shortages, especially for maternal care. Maternal child mortality is one of the biggest health problems that we have in our country. Number of nephrologists is certainly not enough. We have only 5 adult nephrologists and 2 pediatric, mostly IMS fellows. We have 7 renal nurses that trained mainly in South Africa, and very few PD trained nurses. Most of them are HD trained. We have also inequitable access and infrastructure. We have urban-rural division, while 84% of population live within 5 kilometers of health facility. Rural areas have fewer resource coverage, 77% of coverage urban versus rural versus 96% of urban. What are the main impediments for the kidney diseases? They are definitely similar to the other global trends, but are influenced by some local contexts like local lifestyle, health access, and disease prevalence. The leading cause, like in most of the countries, is hypertension. That is one of the leading causes of CKD in Botswana. Number 2 is raising number of diabetes type 2, which contributes significantly to diabetic nephropathy. Number 3 is glomerulonephritis, which often goes undiagnosed, especially in rural areas, because we have low rates of biopsies that are interpreted in South Africa. So what we do the biopsies here, but we send slides to South Africa for interpretation. But what is happening, especially if the patient presents in the rural area, it takes time for him to be diagnosed, referred, and by the time the biopsy is done and results are out, then the disease has progressed, and often these patients present in end-stage renal failure. Number of untreated UTIs and STIs is another health issue that leads into contributes to progress to the CKD in our country. Obstructive uropathy, mainly due to limited urology services, another cause of the kidney diseases in Botswana. Like everywhere else, lifestyle issues are contributing. Our population enjoys high salt, sugar, and processed food consumption, which contributes to obesity, diabetes, and hypertension. Alcohol and tobacco use is also one of the big contributing factors that is contributing to a number of kidney diseases. Another issue that we are dealing with is limited access to early detection and treatment. Many Botswana lack regular health screening, leading to late diagnosis of conditions like hypertension and diabetes, and also, as I mentioned, glomerulonephritis, which often go for a long time undiagnosed until patients present in advanced advanced CKD, stage 4, 5, and basically it's very little that we can do. Especially these challenges are related to rural areas where we have lack of specialized nephrology care. We have a health system based on nurses and medical officer, and often it's not only just the lack of the shortage of staff, but the shortage of basic lab tests that are contributing to some of the kidney diseases to be discovered quite late. We also have other issues like there is we notice that in the clinics we are seeing a lot of patients with polycystic kidney disease. We don't know what is the situation with ApoL because we haven't done any research on any of these genetic diseases. So we are really trying to set it up for the future, and that's something that we ultimately will have to do. From our colleagues, pediatric nephrologists, we know that there is a lot of undiagnosed and unscreened genetic pediatric syndromes which have to be investigated. Another issue that is contributing to the kidney diseases is lack of is use of pesticides, heavy metals, and I especially want to mention traditional medicines. We often see in our practices patients who use traditional medicines that are severely nephrotoxic and often contribute to acutization of already existing kidney failure, or that patient just presents with acute kidney failure, which can often lead to end-stage kidney failure, which irreversibly damage kidneys. And we also have our fair share of autoimmune and other diseases, conditions like lupus that we see in our clinics, but we still need to get proper data on what is the exact percentage. So what are the challenges that we have? We need really as a public health effort to focus on controlling diabetes and hypertension, to improve HIV treatment, promote healthier lifestyles, and do all other preventive measures that will possibly curb the epidemic of chronic kidney diseases. As everyone else, we are facing limited dialysis and transplant facilities that make managing of advanced kidney disease very difficult. I'm just going to give you a brief overview. How did we start developing our services in Botswana? It all basically dates 25 years ago when we began. That was in early 2000. Before that, basically, kidney diseases were, I can simply say not treated, not recognized. But here is the brief timeline. Here are the main milestones in nephrology service in Botswana. In early 2000, that is when the first PD services were introduced, primarily for serving patients with acute kidney injury. That is at Princess Marina, which is our main government hospital in Botswana. Almost 9 years later, we developed our first private-public partnership hemodialysis unit in Princess Marina Hospital, which is a major step in managing chronic kidney diseases. In 2017, a group of us came and we established our nephrology society, which was one of the big milestones in structuring nephrology services in Botswana, primarily with the help of ISN and other partners that we relied on and we are still relying on. Another big milestone was 2018, when the government introduced universal dialysis funding covering both for HD, for PD, and for transplantation, for vascular access, all the medications for renal bone disease, anemia, and that really was a turning point. And I'm proud to say that probably Botswana is one of the few countries the government really has this universal coverage for both private and for all the citizens of Botswana who are in the need to get renal replacement therapy. Basically, government funds the all angles of possible treatment, as I said, including HD, PD, and transplantation, including other accompanying needs like vascular access and medications that are specific for this cohort of patients. Furthermore, from 2015, 20, and 24, government decided to unroll the nephrology services to other regions. As you've seen, our country is huge, and the services were up to 2015 only focused in Gaborone. But then we started developing services in Francistown, which is up northeast, Palape and Mahalape, which is central, Molepolole, which is to the west, Moon, Hansi, and Kand, which are in Kalahari and edge of Delta. So we really try to spread it throughout the country, still not fully covered, and it's not as it should be, but we are going in that direction. What is happening with transplantation program? Transplants are still done abroad, mainly in India and South Africa. And we must say that South Africa has, throughout our development from independence, been a great partner, and we relied a lot from many services, but transplantation was one of those that was done in South Africa, but it was living to living donor. When it came to cadaveric transplantation, South Africa caters only, understandably, for their own citizens. So we really have to acknowledge that, but we have to become independent and start developing our own services. So in that sense, government starts sending patients to India, which is very costly, logistically very complicated. So patients go to India with their living donors, and government funds for everything, from the trip, from stay there, which takes sometimes a couple of weeks up to 6 weeks, and funds for the post-transplantation program, which my colleague will talk about. So that's where we are, and currently we have about 600 patients on renal replacement therapy. Like everywhere in the world, we are more on HD side, 74%, 22 on PD, and only 4 are post-transplant. We're also working on renal registry, African renal registry. We are trying to compile it. So what are the challenges in establishing and maintaining a robust transplantation program? There are a few major issues. We first need to develop local transplant infrastructure and expertise. We are currently lacking transplant centers, organ banks, and trained vascular transplant surgeons. Patients requiring transplant, as I mentioned, were sent to India and South Africa, which is costly and very logistically complex. We have shortage of specialized medical personnel. Botswana has no locally trained transplant vascular surgeons. Country-wise and foreign partnership, like with India's Apollo Hospital for training, critical shortages exist in tissue typing, cross-matching, and post-transplant care. The other impediment is low public awareness and education. Misconception about organ donation persists. We mainly believe that it is unsafe or against tradition, that even doctors lack this awareness. So we need to do a lot of public health work. We need to work on legal framework regarding living and diseased organ transplantation. We need to improve public conception, awareness about organ donation, public campaigns on organ donation that introduce opt-in and opt-out concept, if we should benchmark with other countries for registration, for kidney pair donation. And for the future prospects, we need to seek the motion in the parliament to establish an organ bank and transplant services. We have to work on legislation. The good thing about Botswana is the center for the SADC countries, SADC region. So that gives us advantage to probably other countries, because we already we are center for SADC, and we are centrally located if you look at it geographically. So we could be ideal place for the common bank of organs, like, for example, EU has in the Brussels. So we can also consider to be such kind of center. We can also start kidney pair donation programs. So that's something that we really could start working on. We have, as Dr. Molloy has mentioned, we have a state-of-art circuit to Miller Teaching Hospital, which is not yet fully operational, but is capable when it comes to infrastructure. We only have to work on training of the staff, which is pretty much doable. And really, it's up to us to mobilize the government to explore the other partnership for training and infrastructure. The goodwill is there, so we really need to start moving in a good direction. But as I said, our program is still in infancy due to, as I said, financial, cultural, and systemic barriers. But we really need to significantly invest into infrastructure, education, legal frameworks. It needs to, so our local transplant services can become a reality. Thank you very much. Now my colleague will take over.
Good evening, everyone, and thank you to the organizers for allowing us to speak about our experience with transplant here in Botswana. So I'm just going to speak about where we are and hopefully where we want to be in the near future. But before I begin, I think I need to acknowledge a few people. We've got one transplant coordinator in Botswana, Mrs. Tebogo Bansi. She's helped with a lot of the data that I'm going to speak about in the coming slides. We've got one of our MMed students who's doing a master's. His dissertation is on outcomes of transplant patients here in Botswana. I think we haven't really been publishing data and putting our data out there. So Dr. Bunsibukai is hopefully going to publish soon and we can have the data out there. And Dr. Walter Molloy, who's our Nephrology Society of Botswana president, and is my co-supervisor as well in terms of supervising Dr. Bunsibukai as MMed. So like Dr. Keprik has mentioned, just looking at the map of Botswana and where we are in terms of dialysis, we've got now already between 8 different cities and towns covered when it comes to dialysis services. It isn't still extensive. There's still a lot of patients that are requiring renal replacement therapy. And what we can see is that in our population of 2.4 million, we've got roughly about close to 600 to 650 patients that are on renal replacement therapy. But looking mainly at dialysis, looking mainly at transplant, I think we've only had about 5% of the patients that are on renal replacement therapy that have undergone kidney transplantation. So just to give you a bit of background on transplantation in Botswana, in 2014, the Ministry of Health established the National Organ Transplant Program, and a policy was put together, which was the National Organ Transplant Policy. So to roll out the program, the main hospital that was identified was Princess Marina Hospital, and 2 officers, a doctor and a nurse, were in charge of coordinating the National Organ Transplant Program. We are currently only doing living-related transplants. We haven't embarked yet on deceased donor transplants, and we'll go into some of the challenges we've had. Majority of our workup is done locally, so we work up the donors and the recipients locally. A lot of the tissue typing gets done in South Africa at the South African National Blood Center. So there is a lot of collaboration with South Africa that is ongoing in terms of making sure our program still continues to function. Prior to 2014, our patients were transplanted in South Africa, like Dr. Kevrick has mentioned. Since 2014, 1 or 2 patients still have gone across to South Africa, but the major issues that led to ministry looking abroad was predominantly a cost-saving measure. So in 2014, the Ministry of Health of Botswana signed a memorandum of understanding with the Polo hospitals in India to offer organ transplantation, not limited to kidney transplantation. There was bone marrow transplantation as well as liver transplant and a few corneal transplants as well. And there was a hope to get skills transfer as well. And so the first group of transplant patients then went across in 2014. There was about 5 patients that, along with their donors, that went for transplantation. And in terms of skills transfer, we've had our first, and I think at the moment our only transplant coordinator that completed her training in 2020 during the COVID era as a transplant coordinator. So just in terms of where we are at the moment, we've had 37 transplants done since that agreement in 2014 in India. I'm not mentioning the ones that were done elsewhere. And we can see there's a bit of a gender disparity, predominantly males being transplanted, and we've seen that data from South Africa and Mauritius, as our previous speakers have mentioned. We've seen our mean age for transplant was about 39. We've had 3 HIV positive transplants, patients, and no hepatitis B transplants that were done. We've had 1 ABO incompatible transplant done in India. And the bulk of the causes for the renal failure in these patients that underwent transplant were the non-communicable diseases, as we've seen generally everywhere, hypertension leading, as well as diabetes. So in terms of what induction agents were used for these patients, almost all patients had ATG-based induction therapy. Maintenance therapy, we've got majority of our patients on a CNI and an MMF-based regimen. We do have a few that are on mTOR inhibitors like everolimus, and we've got 1 patient that's on azathioprine as well. And what our achievement from that is that we've had our first transplant recipient that had a successful pregnancy and delivered a child in 2023. So that was our first transplant baby of Botswana. In terms of outcomes, our mortality rate for our patients is at 32%. We've got 2 patients that have had graft failure. 1 is back on hemodialysis and the other is nearing reinitiation. Our patient survival 5-year is 60%, and our graft survival is sitting at 76%. I think that's comparable to data coming out from neighboring countries as well. So we're not doing too badly in that regard. But this is some of the data which I mentioned was one of our colleagues is doing in terms of his MMed, and we're looking at the specific causes for the mortality. Unlike cardiovascular diseases leading the causes, we've seen that sepsis, and predominantly around the COVID era, we had a few of our transplant patients, unfortunately, that did demise. So that was the leading cause for mortality amongst our transplant patients. Our complications are not unique to the general transplant population. We're seeing a lot of patients with urinary tract infections. We've had a few that have developed diabetes post-transplant, and we are seeing a few that have had CNI toxicity. And some of the challenges around CNI toxicity is monitoring drug levels of these patients and the turnaround time, because we need specialized labs. So a lot of these lab investigations are outsourced to private facilities, and So acting upon levels of medications becomes a bit delayed. So like I've mentioned, we do have some challenges. Even though we're 10 years into the program, we still have a challenge in terms of getting a constant supply of our immunosuppression medication. Tacrolimus has become a bit more difficult to get lately. Monitoring drug levels, like I've mentioned, it's an outsourced service to private labs. Some of them go abroad to get results, so specimens are sent across. So the turnaround time and then acting on these becomes a bit challenging. Like Dr. Kebrick has mentioned, we have a lack of awareness in the general public, and so donor availability has become, we have a very limited number of people who are coming forth to donate kidneys to their relatives. And then the issue around skilled personnel, so having trained transplant surgeons, lab scientists, and because there's a multidisciplinary facility, so we're still having a lack of skilled personnel. So just some of our achievements so far is that we've got our first fully trained transplant coordinator. In 2023, the National Transplant Committee was set up. We've formulated transplant guidelines, and we have a race now to get into hopefully our first living related transplants done locally. We have a few centers that have already been accredited. The legislature is in place, and different models are being explored in terms of partnering with facilities in South Africa to see whether we can get our first transplants done in Botswana. Thank you very much.
Thank you, Dr. Sheikh. Now we will pass to the presentation of Dr. Onismas Majuju. Dr. Anwama.
Good evening. Our next presenter is Dr. Onismas Majuju. Dr. Onismas Majuju is from Zimbabwe. He is a nephrologist at Pari Renyata Group of Hospitals, a teaching hospital situated in Harare. He has been practicing as a nephrologist in both government and private sector for the past 10 years. He did his undergraduate and postgraduate studies in Zimbabwe and then studied nephrology in South Africa between 2013 and 2015. Dr. Majuju?
Trying to unmute myself. Good evening, everyone. Is my presentation showing? Good evening, everyone.
Good evening.
Yes, is my slide showing?
Not yet.
All right. Let me try again. Anything on the screen?
Yes. Yes, please go ahead.
All right, thank you very much. Many thanks to the African Transplantation Committee for giving me the opportunity to present on the transplant situation in Zimbabwe. I'm just going to do a quick overview for the sake of time. I'll give a brief history, describe the current situation and how we can set up transplant in Zimbabwe, and then conclude. Zimbabwe is right at the center of Southern Africa. surrounded by Zambia, Mozambique, South Africa, and Botswana. So we did our first transplant, our only transplant in 1992. It was done at one of the central hospitals in Harare. At the time, our healthcare system was doing fairly well. The transplant was done in collaboration with doctors from UK as well as a group scale hospital in Cape Town. The donor was related to the patient, and the procedure went well. Patient received cyclosporine and steroids post-op, but only survived for 2 weeks, and reports say the patient died of sepsis. The program was immediately abandoned because of lack of funding. At the time, that's when HIV was taking its toll on our population in the 90s, and our prevalence went up to as high as 30%. So maybe that contributed to why the program was abandoned. Fast forward 15 years later, 15 years later, one of our central hospitals tried to set up transplant services, and the doctor who was spearheading this also participated in the 1992 transplant project. Funds were mobilized from the private sector, and specialists from the hospital went to India and South Africa for familiarization and short course training. The aim was basically to do skills transfer. So surgeons from India were supposed to come, do some transplants here, and then leave the team here to continue with the program once they are settled. Unfortunately, the program failed to take off for a myriad of reasons, including inadequate financial support from central government. And this central hospital actually did not have a resident nephrologist. And there were also infrastructural and staffing issues. Where are we as of now? We do have patients that are going to India for kidney transplant, and these patients go with their donors, just like what we have heard from other countries. And it's usually the family that is mobilizing resources. At times they get funding from donors. Those on medical insurance may also get assistance. But the general impression is that transplant is very cheap, is affordable in India. If you put up the cost of traveling, accommodation there, and the procedure itself, patients see it as a cheap way. The donor evaluation process, we do it here in Zimbabwe. We identify the appropriate donor, do the counseling and medical screening process, identifying the transmissible infections if they are there, as well as evaluating the renal function. We do discuss complications, potential complications with the donor, as well as the recipient, and still stress the right of the potential donor to withdraw at any time, and also the need for post-procedure follow-up. And we still stick to the KDIGO guidelines for donation, the absolute and relative. But once in a while, we see patients that sneak out and end up in India and get a transplant, some of them with relative contraindications. We see that I would say, a lot with the patients that go out, and when they come back, we also lose track of them. Challenges with this transplant setup is that we do see donor hesitation because of poor education. Our population still think transplant is new, as well as for ethical and cultural reasons. And then some of the potential donors fail the pre-transplant workup because of underlying medical conditions such as hypertension or HIV. And then the toll of traveling is also a major challenge. India is not close anyway. So that's another cost that is to be added. And then when these patients get the transplant, as mentioned earlier on, there's poor follow-up of both the patient and the donor. Usually patients remain in touch with their Indian doctors and getting instructions from India, at times for conditions such as acute gastroenteritis, where the patient may actually need to check into hospital. and have managed acutely. And then obviously the cost of immunosuppressants. Most of our patients who go to India come back with, say, a 6-month supply of immunosuppressants, and when they run out, they have to buy locally, which is quite expensive. And as mentioned earlier on, laboratory support for drug levels. Again, we don't have that in our environment. We have to send samples outside. So what's the situation in terms of dialysis service in Zimbabwe? As of 2018, we had a total of about 482 patients that were on dialysis. We estimate that that number is since probably doubled. And in the States, institutions, dialysis is wholly subsidized, but we do have major challenges with old machines that require frequent repairs, as well as shortage of consumables and limited slots because of obvious reasons. So we estimate that about 10% of our patients who actually require dialysis are getting it, only 10% are getting it, and the rest end up dying before they even get onto the machine. We had established a PD program which was running well, but we have since abandoned it in the last few years because of shortage of consumables. It was running mainly in the state sector. So this is the geographical distribution of dialysis service in Zimbabwe as of 2018. We had about 16 units offering dialysis, both in private and in the public sector. Again, we estimate that the number of units is increased, particularly in the private sector. So is it possible to set up a transplant unit in Zimbabwe? The answer is yes, it is possible. But generally, transplant services should be spearheaded by the state. And the ideal thing would be for it to be done in a state institution so that it benefits everyone else. We may be making slow progress, but it will take a bit of time. It's all about funding. We do have the legislation in place to help us. We do have the Anatomical Donations and Post-Mortem Examinations Act of 1978, which was amended in 2001. We may just need to generate some policies that then will be implemented at institution level. So challenges in setting up a transplant program. Like I said, the major issue is the funding of the healthcare services in our country. Just looking at this, health spending as a percentage of GDP, this is from 2021. We were sitting at 2.79%. This was actually a slight drop from about 3% in 2020. And the highest we got in terms of percentage of health spending, percentage of GDP, was about 10.48, and this was in 2010. Thereafter, health spending as a percentage of GDP has generally been going down. And in 2021, as mentioned earlier on, we're sitting at 2.79%. This is because of the macroeconomic instability that we have faced. From about 2010 to 2017, gradually, there was an increase in health spending. But after 2018, things took a downward turn, and spending has just been going down until 2021 as described. So as you can see, from about 2020 to 2010, there was an improvement, general improvement in health expenditure. And then after 2017, things started taking the wrong way. Compared to other African countries, so Zimbabwe is right at the bottom there, number 49 with the 2.79%, compared to countries like Liberia at the top there, Lesotho at the top there. So we are not doing well in terms of our health expenditure compared to the mineral resources that we have, or even the potential that we have in agriculture. Just some indicators. Our life expectancy as of 2022 was sitting at 59 years. This has slightly gone up to 61% as of 2024. We are still battling with the usual infections. HIV, 11% of our population as of 2022. tuberculosis, 204 cases per 100,000 people, still a major challenge with our healthcare system. The prevalence of diabetes is about 2% as of 2021. In terms of budgetary allocation, as of 2025, for example, health, we were allocated 10.2%. This is way below the Abuja declaration of 15%. But this represents a drop from 2024, where we got 10.6%. And remember, health spending as a share of total government expenditure is an indicator of how the government is prioritizing health. And the government's healthcare spending is projected to be about 2.1% of GDP as in 2025. And again, this is a decrease from the 4% of 2024. In 2022, there's a health sector public expenditure review that reported that our healthcare system, in terms of funding, is heavily fragmented with multiple financing sources to cover operational costs. So institutions get funding from Ministry of Health, get funding from the patients, from insurance, as well as donor partners. And this creates a major challenge for managers at the institution, because they have to report to each and every funder. As you can see there, a facility can potentially get funding from, that's more than 10 funders, and that creates challenges for the managers at the institution. In terms of human resources, for transplant, we need nephrologists. Okay, in 2010, I would say we had one clinical nephrologist on the ground. That has since increased to 5 in 2025. But look at that age group, 30 to 40, there is no one there. In terms of transplant surgeons, we have got none. Interventional radiologists, whom we think are also key in the management of transplant patients. We have got one that we are currently working with. We do have other specialists that can support us in the establishment of transplant services. Just like any other country in sub-Saharan Africa, we do suffer from attrition of healthcare staff. We do have major brain drain to the first world because of poor remuneration. And this may take time to rectify. That's why our number of nephrologists has remained stagnant for a very long time now. This is the structure of our health service in the country. We do have primary health care, secondary care, tertiary care, and quaternary care. We're not talking about transplant, we are at that level of central hospitals. So we do have 6 central hospitals. Of those 6, one is actually a psychiatric hospital. So we are then left with 5. And of the 5, only 1 is manned by nephrologists. So if you're going to talk about transplant in the state sector, it's only that institution which can potentially establish transplant services. But zeroing in on that institution, there are challenges which will need to be rectified before transplant services can be started. Intensive care facilities are limited. One wouldn't want to lose a transplant patient with a functional kidney because there's no ICU to admit them. We've got inadequate lab service, inadequate radiological services. Pharmaceutical supplies are always a challenge, as well as dialysis services, as mentioned earlier on, grappling with old machines, erratic supply of consumables. So it is these major services that are required before we can set up a transplant unit at a state institution. Unfortunately, we have to make a plan. We cannot run away from the fact that transplant will be required. This just shows our population pyramid in 2020, and it's projected to grow. As you can see, this is 2020 and this is 2050. So with the estimated prevalence of 10% of the population being affected by chronic kidney disease, we definitely have to improve our services. Otherwise, we'll continue to lose patients as our population grows. Is transplant in the private sector a possibility? The answer is yes. There is potential. The funding model is clear in the private sector compared to what I demonstrated in the public sector. And in terms of staffing and human resources, the issue of remuneration falls off, and obviously there are less bureaucratic obstacles. The only problem with that is it's likely to be expensive. In our environment, we have no respect of the US dollar. And patients still go outside, still go to India for procedures like spine surgery, prostate. They run away from our environment because of the cost. So even if we set up a transplant service in the private sector, will our patients be able to afford? It's a question that we can continue to discuss. Even medical funders do complain with the charges in the private sector and do support patients who go out of the country. So yes, it may be doable, but obviously it will target the elite, and patients may still leave the country anyway and go outside. So in conclusion, we've come a long way, and I think we still have a long way, especially in the public sector, to establish a transplant service. We need to improve in healthcare funding. The government has to come on board and improve the current state of our health. And then we need to retain our our human resource, so that we minimize brain drain. It's something that we cannot avoid, but at least effort has to be done to try and retain staff, particularly in the state sector. And at the moment, we need to invest in dialysis infrastructure and other supporting services, so that we can dialyze the patients that we have. And as mentioned, in the private sector, there is a role there that we can potentially start dialysis. Thank you very much. That's a quick overview of transplant services in Zimbabwe.
Thank you, Dr. Madzuzo. I am now going to introduce our next speaker, who is Dr. Madalena Manjate from Mozambique. Dr. Manjate works in the hemodialysis unit of Maputo Central Hospital, and she's been working there since 2008. She finished her studies in internal medicine in 2013 in Mozambique and proceeded to do nephrology training in South Africa from 2015 to 2017. She's been working as a nephrologist since 2017 after returning from South Africa and is based at Maputo Central Hospital. And since that time, she's also been actively involved in teaching students in the medical school in the Division of Internal Medicine. Dr. Manjate, over to you.
Good evening. Do you see my slide, please?
Not yet.
And now?
Yes, we can see your slide.
Okay, thank you. I want to speak about challenge in nephrology fields in Mozambique. And the transplant is still a dream for us. Mozambique has a population of about 33 million of people. The per capita income is about $600 US. If the prevalence of CKD is about 10%, this means that approximately 3 million people in Mozambique have chronic kidney disease. There are probably around 300,000 people with end-stage renal disease in our country. In our public sector, there are 3 hemodialysis units in the country that treat both acute and chronic renal patients, adult and children. But we are focused mainly on acute patients. The most causes of CKD in our country is high blood pressure. Second cause is HIV with complication. Third cause is type 2 diabetes. We have a huge list of waiting for chronic dialysis, but for all acute patients, we treat all patients in 3 centers. We don't have any acute patient that has been admitted and will not receive acute. We have the modality of give some section, about 31 section for patient to recover from acute and chronic or purely acute patients. Most of our acute patients are from malaria, gynae complication, mainly obstetric, and some with trauma. We have 3 units in our country. In the south, where I am, we have the unit have a capacity of 16 machines. There are 5 nephrologists working there. 3 of them are Mozambican, 2 of them are Cuban. And we are starting our fellowship program since last year. We have 3 fellows just now. We have about 80 chronic patients in our center, South Center in Maputo, chronic patient, running chronic program. But per year, we can attend more than 300 acute patients. It's why I say that we are mainly attending acute patient. For the center, Beira, we have another unit. It's got 10 machines staffed by a Cuban, 1 Cuban nephrologist. In North also, we have another unit with 10 machines, also staffed by a Cuban nephrologist. We have total of chronic patients in all the country, about 150 chronic patients on chronic program. We have almost 10 kidney transplant recipients, all of them who underwent transplantation abroad, mainly in India. We have many problems because this patient may stay in India at least for 3 to 6 months because we don't have any capacity to deal with the acute complication in this transplant patient. Also, the patient must pay for him, for the donor, and for to stay there, everything in his own account. The immunosuppressive drugs are purchased from India because in our country it's 5 more expensive than India. The patients usually travel to India once per year for follow-up. Also, our patients do online consultation with the Indian doctor. We do not have yet the transplant program in our country. We do not have yet the transplant law. This law is still waiting for approval for more than 10 years in the parliament. We still lack the source for treat acute rejection, perform kidney biopsy, or to manage surgical complications related to the transplant. Patients need to remain in India, as I said before, more than 3, sometimes more than 6 months because of the complication. We hope that transplantation law will be approved as soon as possible. What can I say is our sector, they treat more acute patients. For chronic, we are dealing with big issues because lack of foundation, lack of money. People must pay by their own in private sector. some people have, how can I say, paperwork to do in public sector. I can tell that our waiting list is very long. Maybe we take one patient between 200 waiting list. For that, I can say we have long way to go. We are learning, we are starting. We start our unit in 2008, first one in South. Then we're growing up, but still more to do. Thank you.
Thank you very much, Dr. Madalena Manjate. I ask Dr. Elsa Shisuku to introduce Dr. Maria Kamkoma to speak about the kidney transplantation in Namibia.
Thank you. Good evening, everyone. I'm going to present Dr. Maria Kamkoma, a specialist physician and nephrologist trained in Cape Town in South Africa. Dr. Maria is currently working at Government Hospital in Vindu for the past 5 years. And she's looking after state sector dialysis units and working also at Intermediate Hospital in Katutura, and also working in private sector. She has been teaching part-time at medical school at University of Namibia. Please welcome Dr. Maria.
Good evening, everyone. I hope you can all hear me.
Yes.
Slide. Just a short overview of Namibia. So our population, we have about 3 million people with the last census. It was last year, 2024. And we have approximately 1,000 patients receiving chronic hemodialysis, both in the private and the state sector. I hope everyone can see my slides.
Yes.
Yeah, okay. So we have the Namibia is quite a huge country. We have 14 regions, and in those 14 regions, we have dialysis units in most of the big towns, except for a few towns that don't have dialysis units yet. So most of these dialysis units are run by the private sector, which are manned by physicians, and most of the sectors are actually manned by physicians, and the nephrologists come in to help with overseeing those private units. And in the capital city of Namibia, in Windhoek, we have about 5 private units. And then as from last year, 2024, the government sector, we opened up the first units, the hemodialysis unit for the state sector. So in Windhoek, in Oshakati, and Rundu. So in terms of nephrologists, we've got 3 trained adult nephrologists based in Windhoek, 1 pediatric nephrologist in Wolfish Bay, that's at the coast, and a physician also very involved in looking after renal patients, and 1 Cuban colleague in Oshakati, up north in the country, and 1 transplant coordinator based in Ogwediva, Mary Park, that's also up north, close to Oshakati. At the moment, we have problems. We don't have a vascular surgeon in the state sector for our vascular access, and currently not a lot of patients going chronic PD. It's minimal, maybe 1 or 2. PD, chronic PD, I think the main issue is again with consumables and fluid supplies. So not a lot of patients are actually receiving peritoneal dialysis. So we have 1 vascular surgeon in the private sector, and he helps with our state patients. He's managing most of the CKD patients that need vascular access. So renal transplants, we had the center up north on Gwediva Medipark was doing most of the, or the patients were being referred there for their renal transplants. So mainly private sector patients and a few of the state patients that get funding from the state for their renal transplants. So that center was doing the transplants up until 2020, just with the COVID, they had to stop. So they actually done about 10 renal transplants over about 10-year period. And so at the moment, we have 6 patients that are still alive, doing well. Over the 10 years, we have had 1 COVID death. 1 patient lost their graft on the table, and 1 patient lost or due to sepsis, that patient demised. It's overly immunosuppressed. And then 1 patient had a graft failure, was put back on the chronic program. So that program is about to be restarted soon. It had actually come to a halt because of the COVID. Most of the patients, as I said, the private sector dialysis units have been dialyzing most of the patients, including the state patients. So we used to send all our state patients to the private sectors for dialysis until last year when the state sector we opened our own units. So the patients would be dialyzed in the private sector, and those units usually refer the patients that need a transplant. They would refer them to South Africa. So most of our patients up until now are getting sent to South Africa for their transplants. So they have to go with their donor. And we do the workup. Most of the patients get their workup done in Namibia, and then they get sent across to South Africa. And again, the tissue typing or the typing, the cross-matching and so on is also, the bloods are done in South Africa. For the private medical patients, of course, their private medical aids will pay for their transplants. And then the state patients, again, if they find a donor, they get sent to South Africa, but we do the initial workup and then they get transferred across, and the government pays for that with a special fund that's been set up for these patients. So the main, the main donation we do is live donations. We don't have legislation for deceased donors. And then once those patients come back from South Africa, they're followed up by either the physician or the nephrologist that referred them. They followed up, or at least that post-transplant period, about 1 month or 2 months, they will stay in South Africa. And then after that, once they're stable, they're sent across for further care. So as I said, there's no legislation for deceased donor organ donation. That is still in the process. We're still having those discussions. Again, we've also have these cultural barriers to organ donation, so strong cultural beliefs. So that also has a barrier to, again, organ donations. And most of the patients that require a kidney would often get it from a family member, a person that understands that situation. And then we've got issues with patients getting blood transfusions. Again, I think it's just the poor understanding about the challenges that come with transfusing blood products. And then these patients develop antibodies, and we have problems with cross-matching and so on. That sometimes some patients get difficulties and they don't get their organs because of these challenges. And then also reluctancy from some doctors to refer patients for renal transplants. That's also quite a hindrance. We're trying to work on that we educate fellow colleagues on optimal patient care and early referrals. And again, as I said, there's limited nephrology support. We're about 4 to 5 nephrologists with a population of about 3 million people. So we need more skills. Again, it factors into the fact that patients are not properly managed in terms of access or in just the general well-being of the patients, the taking care of these patients, especially when it comes to prescribing EPO, iron, and looking after their bone disease. Those are the factors that still need to be optimized. and issues with access. Femoral lines that are put in, that's the first access that is available. And then fistulas are done late. And then permanent catheters, if they get put in, they're left in for too long, they develop sepsis. So that's some of the main issues that we have to deal with. So at the moment, we are in the process of setting up a national renal registry, and then discussions around deceased donor organ donations. And then we have a group that we're in communication with, the Transplant Link Society from the UK. We have to collaborate with for training, and they're also helping us to set up our transplant services. And then also we have discussions for the government to also establish its own renal transplant services. That is still in the early stages. We need more skills and surgeons, and then also training of the medical officers and nursing staff on optimal care of our patients, and early referrals for fistulas and transplant workup. So these are just a short overview of the transplant situation in Namibia. Thank you. And then just again, education is very important, and education on blood transfusions. Thank you.
Thank you very much. I would like to thank all the speakers that give us today an overview of the situation of kidney transplantation in the southern region of Africa. As you can remark, there are a discrepancy between all the countries. Some countries have, like South Africa, have a kidney transplant program with deceased and living donors. Other countries don't have a program till now, and some other done some few kidney transplantation with the help of foreign teams. So I think that, as you can see, the situation is not very good in the region of South Africa, and I think that we should have a contribution of all African countries to improve the situation in the southern Africa, but as well also in the other region. So the discussion is open. Please, if you have a question, you can put them in the chat box. The first question come from Dr. Malcolm Davis, and he said, given the dependence on related living donors, have colleagues found similar challenges to identifying healthy donors as they have in South Africa? So please, the question is for all the speakers. We can ask our colleagues from Botswana, from Namibia, from Mozambique, Zimbabwe.
If I may kind of suggest, and I think it's a very good motion, and it really makes sense that we rely more on South Africa than on India. But from our experience here in Botswana, and we are really neighboring country. Gaborone is 20 kilometers from the border. It is really, cost is one of the biggest restrictions. And the other issue is that South Africa, especially when it comes to a disease donor program, it's only restricted to its own citizens. So it will really make sense that we kind of unite, and countries like Namibia, Botswana, Zimbabwe, Mozambique also benefit from diseased donors, and at the same time, we in same reciprocity that we contribute to the bank of organs. That will be my take on that. But certainly, we would like to establish. I mean, we have a good ties, but as I say, the cost is real prohibition. I mean, when you compare the price of transplantation in India and South Africa, we are talking about really like 1/3 of the cost, including the trip and including the stay there for sometimes up to 3 months.
Another question or remark from Dr. Shital Shiba. I think it's evident that cost is a major barrier to kidney transplantation in Africa. This limits specialist intervention as well. To avoid transplantation occurring in India and rather building functional and skilled staff transplant units in Africa, which will increase access to kidney transplantation program. Please comment on the potential of financial partnership policies from neighboring continent. What do you think about this? Dr. Bongboye, Dr. Jamel Saadi, and all the panelists, you can participate, of course, to the discussion.
Brief me as regards this particular comment. I think I'm one for encouraging a lot of collaboration within Africa. We have common problems, we have common challenges, and I think we're best suited to sort out our problems amongst ourselves. I think it will be difficult, though, to expect that South Africa would, with limited number of cadaveric donors, will be willing to make those available to people from other countries. Except, of course, like you did mention, there's the possibility of reciprocity, but the challenge would be the problems of transportation of organs from one country to another across country lines. I think until we can properly integrate and coordinate things within ourselves, that's going to be a very tough challenge to deal with. But I expect that Dr. Malcolm might want to comment on that.
Yeah, thank you, Dr. Babu. I mean, I would say, I think the question is formulated is perhaps another way of interpreting it is that obviously there's room for us to look at cross-border skills transfer. So one of the, or a number of the speakers have highlighted the lack of access to skilled immunologists and skilled pathologists. It's not that the tests can't be collected or the kidney can't be sampled, it's that there's no one in country to interpret those results. And so one of the ways in which we might be able to provide assistance is obviously sort of skills transfer of those sort of scarce skilled professionals, the immunologists and the pathologists, providing interpretation of those results to other programs in other nations. And I think that certainly that's something which I've raised as part of my talk at the upcoming CHOT meeting, that it's something perhaps we can look towards as a committee going forwards as a way of stimulating transplants elsewhere.
Another question from Dr. Shital Shiba, I think, at Professor Malcolm Davis. Despite presented data on Black South African donors whom are often precluded from donation on the basis of medical conditions, are there any incentive which can be provided by transplant centers to increase the number of potential donors to increase living donation in South Africa?
So I think that's what our data suggests, is it's not that there's a shortage of people coming through to be worked up as donors. it's that most of those donors turn out to be unsuited for transplant. So, as I said, it's sort of 3 out of every 4 potential donors excluded on a medical basis. There's a smaller percentage who are excluded on an immunological basis. So certainly one of the sort of like ways in which we could make use of those otherwise medically fit is to invest in paired donation programs in the state sector, which to date we haven't really done. It's been largely in the private sector. I think that UCT has had a few paired donations in the state sector. I think that what Dr. Chiba is also alluding to is the sort of potential concern for, which was also highlighted by other speakers, for living donors in terms of lack of education amongst our people regarding the safety or possibility of donation. And certainly sort of community outreach programs, increasing the general public awareness of the possibility of organ donation are one place to start, and that would potentially also have knock-on effects in terms of improving donations from in our deceased donor program. There have been sort of attempts, or there have been considerations of other mechanisms to incentivize donation. So, for example, thinking about providing the recipients with accelerated high levels of care or I beg your pardon, the donors with accelerated or higher or access to nephrology services and or dialysis in the future should they need it. But obviously that sort of those sorts of incentivizations have to be carefully balanced on an ethical framework, because one has to be cautious in a very resource limited setting of providing perverse incentives for donation. So it is sort of a tricky balance to have to walk. Thanks.
Thank you, Dr. Malcolm. I think through the different presentations, we see that there are many problems in the South Africa region. Particularly, there are no many nephrologists. There are a problem about legal framework and about training. So I think that the collaboration between all the countries is mandatory, and the Afra Transplant Committee is actually preparing a directory of all the facilities in African countries that works in the field of transplantation, of course, such as immunology departments, pharmacology, pathology, and so on. So I think that we should collaborate together and try to have solutions, practical solution to start a kidney transplant program in our continent, and then try to maintain this activity. I also take this opportunity to speak about the first forum of African donation and transplantation that will take place this week in Mauritania from 16 to 18 in this month, May. So I ask all colleagues, all African colleagues, to try to join us in Mauritania and to participate, to elaborate together a declaration, the declaration of Nouakchott, as how to create and to maintain kidney transplant programs in African countries. I see also a remark or question from Dr. Walter Mollowy. In our region, skill transfer is part of the problem, but the biggest problem for those with the skills is resources to be able to practice the skills they have acquired in their home country. You may know how to do a biopsy, but the skill is irrelevant if you don't have a biopsy needle. Is there any other questions or remarks, please? I would like to know the point of view of all our speakers about the situation of the neighbor countries. What do you feel about all the presentations?
I think from a South African perspective, we are in awe of the work done by our colleague nephrologists in our neighboring countries. We appreciate that they labor under much harder conditions than we do. From a personal perspective, it is a great privilege to see so many of the presenters today being nephrologists who trained with me at WITS or were fellows when I was a junior consultant. I think it's evidence of the sort of the benefit of building networks across the continent. Thank you.
I would like to echo Professor Davies' comments. I think it was very eye-opening and sobering to hear all the presentation, and despite all our difficulties in Mauritius, we can see that many of our colleagues in Southern Africa work in very, very difficult circumstances, and hats off to them. I just want to comment, one thing what surprised me is that so many patients are going to India from Southern African countries. And just in Mauritius, the last few months, I've become aware of a number of private companies that is kind of act as intermediaries for people to seek a treatment and get a transplant in India. And I'm actually quite worried about that because we have mentioned all the difficulties with our program so until the last few months where were isotopic GFR machine wasn't working, the gamma counter, and so many patients have kind of been waiting and deciding to go to India in the meantime. And as somebody mentioned, the price is very attractive, and there will be a point where all the investment we do in Mauritius, we just still can't compete with the value of the private centers in India. And well, in the Mauritian context, we need to get our act together quite quickly. Thank you.
Thank you, Dr. Minuan. Just a last question about the organ trafficking and transplant tourism in the region, in the southern Africa region. Have you any data about this issue in the region? Please, I ask all the speakers. Please, Dr. Mazduzu from Zimbabwe, Dr. Abichir from Botswana, Dr. Madalena from Mozambique, and Dr. Kamkunar from Namibia. Have you any comments about this issue, please?
We don't have any data on that, and I don't think personally in Botswana it's happening. But you raised a very valid and very important issue. Because if we don't think about it preemptively, the situation may change and things may happen. We are all the signatories of Istanbul Declaration, and at recent AFRAN, we had a very interesting talk about it is actually happening in some of African countries. So I think that it's important because we are all within SADC region, that we all unite and have a similar legislation and fight this problem before it happens. Otherwise, reality can overtake us, and things may happen before we even become aware of that. So I think that is something that we should certainly work on while we are working on our legislation. So we preempt it from happening. Yeah.
What's about the other countries?
Thank you.
Namibia. Oh, sorry.
Yeah, that's fine. You go ahead, Maria.
From our side, we don't have the stats, but you sometimes will hear patients mentioning that they are sort of collecting funds to go to India, but I haven't really come across any cases as such. But I think it's also very important just to be alert on what is happening. Just to on the lookout.
Thank you. It's the same for Zimbabwe, because the cases that we are dealing with are actually very few, the patients that go to India for transplant. So we don't really have a major problem with organ trafficking. But just to comment on India as a destination for these patients, for us, what we have realized is it's not just for kidney transplant, but even for other services, particularly surgical procedures. The major reason being that it's cheaper there, but also from the Indian side, they are very business minded. They push for this, they advertise. At times, they actually send agents to come and canvass for patients. At times in our dialysis units and advertise their hospitals. So the onus is basically on us to improve our healthcare systems and to possibly make the transplant cheaper. Patients don't really want to go to India, but it's out of desperation and they end up going there. So anyway, thank you very much to the transplant committee, the Afran Transplant Committee, for organizing this. I think it's good to continue the discussion and have more presentations of this nature so that we continue building the linkages. Thank you so much. Many thanks again to South Africa, represented by Dr. Davis here, for training most of us in nephrology. In Zimbabwe, we have got 3 nephrologists that have trained in South Africa, and I know a number of nephrologists in the region have been to South Africa. So thank you very much. We hope we'll be able to expand the program of transplant in the region as we improve our healthcare system in our respective countries. Thank you so much, everyone.
Hi, good evening. For our case in Mozambique, we have very few patients. Usually the patient before go to the India, they come and they do checkup. And usually we do with the relative, first degree relative. We don't have, I don't know any case of organ trafficking, but they are very few, and we know the relative, we know the patient, we know the donor, we do the test, then we send to the India. Even in India also, they check it again. Thank you.
Thank you very much. I think it was very interesting webinar. It was long, but it was our choice to include all the South African countries to see the situation in this region. So I asked Dr. Bong Boye, the chair of the Afran Transplant Committee, to conclude the webinar. And of course, I thank all the participants, all the moderator, the speaker, of course, for their commitment to share with us the situation of kidney transplantation in the Southern Africa region. Dr. Bong Boye, please.
Yes, thank you very much, Professor Bacha. I really must start off by thanking you for your work as the chair of this subcommittee of Afran. I mean, just listening today and looking through what has been discussed, the number of participants, I think this has been a very successful webinar that has been very, very well attended. And I see that quite a number of us, despite how long it has taken, have stayed on right till the very end. And that is a testament to all our speakers today who have given us very precisely and succinctly the situation in their various countries. And it just shows that, around various countries in Africa, we have similar problems and challenges. And certainly we can work together to try and ensure that we surmount these problems. And this is one way of getting around that. I also would like to thank all the moderators who have guided us through our discussions today, and want to thank all the participants who have stayed on till the very end. This is the 5th in our series, and certainly I'm sure after listening to the discussions today, we'll all be looking forward to the subsequent ones. So thank you, everybody, and have a good evening. And look forward to seeing you all in Nouakchott for those of you who will be joining us there. Have a good evening.
Thank you. Good evening.